Hi, I'm Dale Sherbeck, and welcome to the HQ, a CHA Learning and Healthcare Can podcast serial where we dive into healthcare issues and topics from the perspective of its people and discuss them with those that are leading in the health system. Together, we'll try to unpack these topics and learn what actions are being taken to innovatively solve them today. In one of our first episodes on the HQ, we discussed with Kristen Winter of Sunnybrook the importance of immigration and creating pathways for internationally educated health professionals. This topic has certainly been one that has garnered much attention from national associations like our own, the media, and government. Kristen was also well quoted that we as a society, and certainly in the form of our systems, need to find meaningful ways to bubble wrap these individuals and their families and safely help them to traverse our systems and to get them from point of being a new Canadian or applicant to the point of working in our health system in a role they have been trained to perform. The key word that continues to come up in this context is navigation. While there are actions that can be taken and are being taken, the more we collectively pull on the threads of this issue, the more complicated it is becoming, and the more that is being revealed around the structural barriers that are making navigating incredibly difficult. Indeed, instead of well-marked paths, many new Canadians find dead ends and locked doors. There is a very real human cost and impact to all of this. It certainly, and most importantly, has an incredibly detrimental impact on the newcomers and their families, which in turn translates into social and health costs. But as we've discussed, it is also costing our health system when the people struggling to navigate arrival, licensure, and employment are the very professionals we're desperately needing to shore up our healthcare organizations and ensure uninterrupted quality services. In short, every Canadian should desperately care about this issue. One organization that cares very deeply and is doing just that is the National Newcomer Navigation Network. N4, as it's called, is a national network for the diversity of providers who assist newcomers in navigating these complex Canadian healthcare and social service systems. N4 provides opportunities for professional development, education, virtual discussions, networking, and the sharing of data and resources. N4 aims to promote best practices in the field of newcomer navigation with the ultimate goal of improving the experience of newcomers to Canada. N4 is hosted here in Ottawa by the Children's Hospital of Eastern Ontario, CHEO, and to be clear, it was founded in 2019 before the pandemic, which also speaks to the fact that this is also not a new problem. From N4, I'm joined today by Christine Kouri, the Manager of Health Equity and Diversity at CHEO. Christine has over 30 years of experience in the Canadian healthcare system and is known for her initiatives and expertise in equitable healthcare across socio-culturally diverse and marginalized populations. Upon obtaining her master's in health administration, she was recruited to CHEO to lead the development of their patient experience department. As the manager for that department, she led CHEO's efforts to ensure an optimal experience for Syrian refugees that were welcomed to Ottawa in the early 2016s. In addition to oversight of the N4 project, Christine continues to lead CHEO's health equity efforts for the most vulnerable patients and families, including newcomers. We're also joined by Dr. Sahar Zohni. Sahar is the project manager for N4. She has a master and a doctor's degree in pediatrics from the Alexandria University in Egypt and a master of health administration from the University of Ottawa. Sahar brings to the role over 25 years of work as a clinician, lecturer, researcher, and the passion for quality improvement. She has worked internationally, including Egypt, England, and now Canada. Sahar's career path makes her the ideal leader for the N4 team to create a national network aimed to improve the experience of newcomers in navigating Canada's complex health and social services. Hi, Christine and Sahar, and welcome to the HQ.
Hi, thanks for having us.
Hi.
Yeah, thank you for joining us today and for the work of N4 and to share with us, better appreciate this, I think, very complex issue and provide a lens on it in terms of things that can be done and that are being done. So maybe, Christine, I know I gave a very brief introduction of N4 at the start, so perhaps we could start with you providing a more fulsome description of N4 for our listeners and stakeholders here.
Sure, I'd love to. Thanks. So N4 really, as you described, I was supporting a large amount of Syrian refugees that we received in Ottawa and specifically at CHEO in early days of 2016. So, my role at that time and continues to be to ensure health equity for our vulnerable families. So newcomers obviously are very vulnerable. They don't understand our system, sometimes language barriers, sometimes cultural barriers. So in 2016, all of a sudden, we unanticipatedly received a large amount of children with very complex health needs. About a third of them that we saw, the 300 children we saw in the early months, were really quite complex. Shocking to our healthcare providers who are used to seeing children with congenital issues from day one.
Mm-hmm.
Here were children, up to 13, 14, who had never had access to the healthcare they needed. And so we had malnourished children, things we'd never seen. Our wait list for wheelchairs doubled overnight as children had no access. They were using strollers to move around. These children, genetic issues we'd never seen at this side of the world. And so our geneticists were fascinated by this, but it was an increase in clinical things that we saw. But accompanying that was all the equity issues that really challenged our staff. So seeing these families who were traumatized, we'd have moms who were hoarding food because they didn't know when the next meal would arrive. Clearly crying, and we weren't understanding what they were saying. We had an increased need for interpreters, so we were onboarding interpreters like crazy. So at that point, we were fortunate that the Ministry of Health, we put up our hand. The Ministry of Health gave us a bit of funding to do some navigational support for these families. And so what we did, which was later led to N4's start, was that we had this navigational support. Originally, we had one position that families could just call, or staff, to say, I'm struggling, I need more help, I don't understand what's going on. And truthfully, there were struggles on the family side who were saying,
Mm-hmm.
I've gotten this voice message in English. I only speak Arabic, right? So this staff spoke Arabic and could answer those questions. Or they'd say, I don't understand why they want this treatment for my child. I signed a consent form, but really, I didn't really understand. Can you help me? So she would help those families along. And on the other side, we were helping our staff to understand what are refugees? What are their specific needs? How can you assure that you don't add more trauma to their experiences? Should you ask questions about their experience in the refugee camp, or should you not? So we had this navigational support, came to the attention of Immigration, Refugee, Citizenship Canada, who were starting to now settle these families in other cities. And those hospitals were starting to also say, oh my gosh, we're overwhelmed, we're struggling. And so they wanted us to share our experience and shorten that learning curve for other centers. So Sahar was brought into my team and did a fabulous job of really writing up this short and dirty website we did called Simplifying the Journey, which really talked to the tools we developed. Please use our tools. Here's our Arabic pain scale. Please use that. Here's this video that we did for mothers to understand, why do you do G-tube insertions? Because we were finding a barrier there. And from there, IRCC said, this is great. We have this new innovation grant. We want you to grow what you're doing to help, and over to you to brainstorm. So Sahar and I sat down and thought, what is the gap? Because we don't want to overlap. We know everywhere resources are short. And what we really found was the settlement workers who do a great job of welcoming families, of showing them how to get an apartment, how to get a bank account, how to get to the hospital, how to use the bus system, how to take English classes. We usually don't talk to each other unless there's a big issue. And so we really do need to have ongoing relationships to really feed into each other's systems and make us more seamless from the perspective of newcomers. And we also saw that there wasn't a network, and newcomers were not well appreciated for the vulnerability they have. We often talk about, and rightly so, about Indigenous families and LGBTQ communities, but we didn't
Mm-hmm.
have an accurate perception of newcomers of vulnerable sector. So we formed this platform, this network, so we could our tagline is connect, learn, and collaborate. So we can talk to each other, share resources, why and reinvent those pamphlets and so forth. And then also collaborate. So we've done some great collaborations, like developing toolkits for our newest vulnerable populations, the Ukrainians that are on visas, our Afghan refugees. So we have toolkits what we've developed as a Canadian community, and then put them out there for great use. So that's a little bit about, we have education platforms and so forth. What most recently happened this year, so the IRCC was pleased with what we were able to accomplish. We have over 1,000 members, 350 organizations. The IRCC came to us earlier this year and said, we have this health human resource crisis. Do you think we could leverage what you've done, given you do that cross-sectoral collaboration so well, you have these tools, can you help us with this? And that's what led to the additional efforts that we're undertaking right now of bringing people together to really look at not only equity for our newcomer patients and families, but equity for our newcomers who are our colleagues, our nurses, our physicians, occupational therapists, physiotherapists, and so forth, to make them successful. And ultimately, we've all, after George Floyd's murder, we all put out equity statements, how we would do things better. Every organization has said we need to diversify our staff. We don't represent the communities we serve. So that's another added bonus to having newcomer nurses and physicians join your workforce, is that you're going to represent your community better, because that's who's broadly in your community as well. So we're really excited about the work that we're undertaking.
Yeah, that's a great addition and connection. We've been doing over the past month and a half a series on equity, diversity, and inclusion, and looking at different lenses through that. So I think it's great that you're finding a way to leverage a human need in some respects, a social need, but also connect it back in terms of our organizational needs as well, and how we can sort of live and breathe our values. So maybe Sahar, given your own sort of exceptional sort of lived experience and your own status as a newcomer to Canada at one point, what are the hurdles and challenges that internationally educated health professionals do need to navigate and overcome to find appropriate employment in Canada?
Which is not a very easy question to answer, and it
Sorry.
needs a lot. It needs a lot of time, but I'll try to kind of make a short list. Let's call it that way. So, although the Canadian healthcare system has really relied historically and currently more and more on the integration of our internationally educated healthcare professionals, especially the internationally trained physicians and internationally educated nurses. And again, we've seen with the COVID-19 how our system has really struggled with all these shortages in the healthcare system. And I think post-COVID, if I may say post-COVID, it's even worse, right? So challenges really start way back, pre-arrival. So pre-arrival, having information, the correct information, being available for an immigrant who has healthcare background and who are thinking of immigrating to Canada is one of the real challenges, right? And really, it gets them to maybe make the decision to come to Canada or not. But by having this poor information, you're kind of, you're not being very transparent, right? And also information around the they get about their own profession. So from the regulators, from the colleges, all the really the website they have to go through to find the information, and the recency of this information. Is it recent? Are the websites updated? Are they not? So that's another challenge with the information piece, right? And then having their credentials being accredited. So foreign credentials is always a not an easy thing. So they have to submit all their credentials. There is a cost, of course, that goes with that, and also there is the difficulty in getting these credentials right into the system from those institutions outside of Canada, right? Imagine people coming from war zones now, for example, how can they prove that they have these credentials? And how long does it take? So time and money and anxiety, maybe for the internationally educated professional, and also lots of communications, and then navigating all these policies. So our healthcare is, again, it's regulated. It's a regulated profession. So, and there is a lot of provincial regulations that they have to navigate. They have to navigate the different practices, the different procedures for license and registration, right? And then they have to pass the exams. So there are standard exams that they have to pass, and that is takes time, and it's again costly. So while they're taking the exams, are they able to support their families? Are they taking on jobs that are non-healthcare just to survive? And how long will it take them to take these exams, right? But we then, I think everybody then faces like the real bottleneck, which is really finding the residency for the internationally educated, for the internationally trained physicians and
Mm-hmm.
IMGs, which is really the real bottleneck there, because they have to get this residency piece, and the residencies are not their numbers are not really enough. So the number of residencies are very limited, and they actually have to, in a sense, they are competing for a very small already number of residencies that are only offered to internationally trained physicians. But in that category, they're also in a competition with the Canadians, who had to go abroad and complete their education, maybe, in other countries outside Canada, and they're coming back. So the Canadian international educated physicians or IMGs who are coming back. So they are all in this, they're all kind of in this limited spot for those residencies. So this is really kind of a big bottleneck that they have to pass. And by the time they are applying through CARMS, which is the match program to get residency, they are facing another challenge, which is proving their recency of practice. So imagine, having to go through the exams and then apply for CARMS. So by that time, many of them would have passed this, the time for to prove the recency of practice. So they would have to go back to their country of origin where they have a license to practice, leaving maybe their families here in Canada. And again, their mental health status, their worry about the finance piece and supporting their families, right? And they have to go back and maybe practice for 6 months or to a year, and come back with this, to apply again now that they have this recency of practice. For some of the IHPSs, it's also the Canadian experience. So again, another thing that they have to prove, which is kind of a, how can I prove that I have a Canadian experience if I don't have a license to work, right?
Mm-hmm.
So it's kind of very challenging, right? And it's sometimes it doesn't make sense. And I know there is a lot of discussions now in Ontario on removing that, right? But I mean, like, it's because again, it doesn't really make sense. You go to the UK. I've worked in the UK. No one asks for a UK experience, right? Or
Yeah.
so I mean, like, it really has to be something that really has to be looked into. Another challenge is if they are going through the practice readiness assessment. So they're not going through the residency, but they're going through the practice readiness assessment. We only have 7 practice readiness assessment available in Canada. So there are provinces that do not offer the practice readiness assessment, for example, Ontario, and the ones that do offer a practice readiness assessment, a PRA program, they take very limited internationally trained physicians into their programs. Again, it's because of the lack of the assessors, and that's another challenge.
Yeah. So, I mean, you paint a very vivid, overwhelming picture, to say the least, in terms of the barriers that these people are facing. And if I was if I was in their shoes, um, I would see, giving up as an easy solution to sort of getting on with some of these things. I mean, you've identified the challenges of the system itself, right? So, residencies and issues like that are, manifest regardless of whether you're coming from another country or not. It's already a problem in terms of how we produce physicians in this country. And they're coming into a system, therefore, that is already extremely complicated and over taxed in some respects, facing issues about time, money, paperwork, complicated processes that travel between different countries. So yeah, my heart goes out to the people you're working with, and you certainly evidence why you're needed. So maybe continuing on with that then, and I'm not sure who wants to answer maybe this next question. I mean, we hear stories anecdotally and some, lived sort of experiences of, finding or meeting, internationally educated health professionals working in jobs that bear no resemblance to what they were trained for, driving taxi, working in hospitality, wherever that might be. Do you have any facts and figures on that, how extensive that problem is, and how many of these people are in our country inappropriately employed?
Yeah, so there's not great data, but what we have seen from Stats Canada most recently is that uh, about 40% only of our internationally trained nurses and physicians are actually employed in their field. So that means 60% are doing those survival jobs. We've heard the rumors, right, of taxi drivers. If you go to environmental services at any of our hospitals, chances are you'll find an internationally educated nurse sitting there who's just has become lost in the system. And I know Kristen spoke about that, and she's found 9 nurses just by looking within her own organization most recently, and supporting them. So we do know it's a huge problem. And then on the converse, we know, job vacancies have never been higher. We're 90% higher in terms of vacancies this year versus last year. We've all seen it probably anecdotally in each organization, how the retirements are just huge at every organization. The nurses have kind of had it with, COVID just sent those who were petering on the edge of deciding, am I leaving the profession? COVID just sent them over the edge. I just can't work in masks and gloves and gowns. This is just not a quality of life for me. And the understaffing, so they're doing, double shifts and not feeling like they have a good work-life balance. So it's never has it been a more acute situation, and never have we have so many people who are underemployed that are available, who some of them do say, I wish I'd known I wouldn't have come to Canada and uprooted my whole family if I'd known how difficult it is. But
Yeah.
they're still here, and they're still willing to we can use the investment they've made, their home countries have made in their education, their experience, to solve our problem. It's a win-win that's available. We just need to overcome these hurdles and get folks working together.
Yeah, I totally get that. Um, so, I mean, so moving past like the barriers and things that you've just described, and the system obviously could be doing much better. I know from my own experience of having lived abroad, that, not everybody living in another country necessarily brings all the right skills. And, that doesn't mean that they can't learn them, but they nevertheless, they may not have all the skills necessary to take on the work that they aspire to. So through your work, have you identified some common skill gaps within your network that you could identify that might need to be there to support newcomers?
Yeah, I'll speak to. I am a nurse by training, and so I'll speak to that, and then I'll hand it to Sahar for the physician. What we've seen the internationally trained nurses is almost comparable to me. I trained, and we're having a reunion this year, 35 years. I would not be safe as a nurse in Canada right now, because my training, what we did as nurses then would be, what we would put in an ICU right now, we put on the units. Those
Hmm.
dialysis patients and the chemo patients, I would be totally uncomfortable. And so we see maybe a comparison to IENs who don't do that level of work in their home country. Say you're from the India or Philippines, they're not used to critical care training that we expect of commonly of our nurses. So there is that what they call in the industry a bridging need.
Mm-hmm.
So there are programs right now, and Ontario has one that the Ministry of Health is funding, where they'll do these bridging programs and get them up to the Canadian speed of things. So they've got the basic nursing. They could function at an RPN or an LPN, depending on your province, function. So they could get jobs meanwhile by that. So they assess them and they have those jobs. And then we need more of what they're starting to do is these bridging programs to bring their skills up so they can be a full RN where we have so many gaps as well. So it really is a win-win. We do have gaps in RPNs and LPNs, so that helps with that gap. And then it also helps to transition to those RN jobs.
Mm-hmm.
One of the things we've looked at and we've seen as well is even if you're employed and you talk about that skill level, there's also the cultural differences that can't be underestimated between Canadian cultures and other cultures. So, we've had very specific examples where I come from is pediatrics. If you have a 14-year-old who wants to talk about contraception or their gender identity, that might not be a conversation you've ever explored or ever
Mm-hmm.
been talked about in your formal training in another country. But for us, it's commonplace. Or Indigenous health and the sovereignty of Indigenous health and all those important conversations. So we've at N4, we saw that as a gap. They'll get some of that if they do that bridging and supervision, but we've also added in a short program of 12 weeks for IENs and ITPs to take so they could better understand their own cultural beliefs, because it's hard to identify your own culture unless you really think about it, and then to also understand the Canadian and what might be the differences and how will you adapt your approach to make sure that you are successful in your Canadian employment so you don't have families complaining about your approach or college complaints or so forth. So we want them, once they get the clinical skills, we really want to make sure they're also successful in their place of employment. So maybe I'll turn it to Sahar for some of those physician challenges.
Yeah, but I'll just sort of add. I mean, I think that's brilliant, and I think and then great lens sort of to look at things through because as we're discussing, we're asking Canadians to look through those same lenses about their biases and things like that too. So I mean, you certainly elevate the need for that if your culture has been developed outside of this country. So yes, over to you, Sahar.
Yeah, I think it's very similar for physicians. So really, it's not the clinical skills, right? Because they get assessed for that piece. But I think it's understanding the culture, the Canadian culture, and really understanding, how diverse. Is our community in Canada, right? Because they might be coming from a country where most of the country are the actual citizens, right? So Canada's unique in that it has such a diversity of populations that they deal with, and I think it's again the Indigenous health that they have to have a good understanding about. So that's why, as Christine mentioned, we have this program that we partnered with St. Paul University here in Ottawa,
Mm-hmm.
and it's going to be a 3-month program. We're going to be offering it to ITPs and IENs, so both. And we opened registration for that program, and we have our first 60 are going to start next Monday.
Oh, wow.
We're going to be offering it again in the winter, so keep an eye open for that. And it's going to be in English and French, so we'll have 2 cohorts, and it's offered to IENs and ITPs from across Canada. We have our current cohort, participants are coming from 26 plus countries. So, I mean, it's amazing. It's amazing to see how we're also hoping that this program would kind of touch on their needs when it comes to understanding the Canadian culture, conflict resolution. We heard a lot about, interpersonal communication might be an issue, and how can we empower them by touching on that. So we have, we have modules around that. There is a lot of mental issues when it comes to, as you were saying, Dale, it's not an easy journey, right?
Mm-hmm.
So how to support yourself, how to reflect on, on all that you're going through this licensure, journey. I think it's another piece that we're going to be touching on, the professors at SPU program. Another thing that we offer them, which is, I think it's, again, I talked about, which was one of the barriers and challenges, is the information. So information is kind of, you know, they find information over, in a lot of websites, so they have to, and the information might not be regularly updated. So this is why we launched an RSS feed where we would be bringing this information to them through N4, and they can subscribe and they can receive an, just get all the information from their colleges, from the regulators, from regularly in their emails. And we are hoping also to host like some professional development sessions. So as Christine mentioned, understanding consent, understanding gender, conflicts, all these issues, I think we will be tackling through our speakers. We're going to be hosting panel speakers for those discussions. And we've built quite an information portal at our N4 website. So we curate a lot of e-learning and a lot of resources through our resource toolkit. So recently we've been actually focusing on having resources for our IEHPSs added regularly. So again, English and French resources are being added. And our community of practice, I think it's another thing that we want to share. So we have launched a community of practice. We have 4 working groups. We just launched our first working group for the internationally trained physicians. And we have a lived experience at the table with us. And we are going to be launching a table just for lived experience to kind of get their voice and make sure we're consulting with them if we're making any recommendations on how to leverage their expertise into the and leverage them into the Canadian healthcare system. So that's I think another thing that we want to engage them and get to hear from them and get their feedback on.
Well, it'd be very interesting to hear their stories after they finish their program and what difference it's made in their lives and their professionalism. So potentially maybe a bit more of a difficult question for you. I appreciate I'm going to tread into some maybe sticky water. So, I mean, it may surprise many in Canada, but I think as you know, Stats Canada has recently released information that reports that 1 in 4 Canadians don't speak English or French as one of their own first languages. So, I mean, that's a huge number of people. So again, I appreciate the question may be a bit more loaded, and I don't want to put you in an uncomfortable position yourself. So certainly answer it as you feel comfortable. But, from your data and your perspective, how much does language represent a barrier to employment in this country compared to, say, race, culture, religion, or country of birth?
Yeah, we certainly have, being in Ottawa, our hospital is very focused on wanting to be bilingual. We serve English and French people. So official languages is very important. And yet we have all these other languages that these folks come with. The international nurses and physicians actually have a language requirement to do twice. So before you immigrate to Canada, part of your process and being evaluated is, how educated are you? What's your age? What's your income? Can you support yourself? Because we don't, refugees we support, but immigrants, we expect them to take care of themselves. So there's all this evaluation in addition to an English test. So they have to pass a certain level of English. Once they get so you're admitted to Canada, you're welcomed, and now you want to be a nurse or physician, you have to do additional testing at quite a high level, and you have to pass in an official language. So it's quite stringent, and it is a barrier that some of the nurses and physicians face. There's various tests depending where they are across Canada, which is another barrier, and some are a little less relevant than others. So they'll ask them questions about IT instead of about medicine, which they would flow through. But if they ask them technology terms, I would probably struggle as well. So, but they do have that secondary language skill that they have to pass. So it should not be a barrier once they are in their setting.
So building on that, and I guess sort of maybe like the prevalence, like, and as we discussed, right, within our health systems around racism and other kinds of oppressive, exclusionary practices. I mean, what role does the increased attention being given to equity, diversity, inclusion sort of policies and programs mean for our internationally educated health professionals? And maybe, follow up to that, what more is needed?
Yeah. So certainly it's a facilitator. Before, we talk about Canada as a mosaic and not the melting pot of the states. But we all acknowledged, especially during the social justice movement that began in the summer of 2020, that we could do better. We do have biases, we have unconscious biases, and we have systemic barriers. So as we dismantle that, that's all important work we're doing at the hospitals, and a lot of it focuses on our patients and families. But the side effect is that it's going to help our diversity within our workforce, as well as people become aware of their biases and so forth. And I know that during the work we're doing at CHEO, one of the primary stories we heard was from staff actually who came forward and said, I'm a Black physician and my colleague says, oh, and starts touching my hair because said, oh, I've never touched Black hair before. These
Mm-hmm.
microaggressions are really a downfall. So if we can correct those things, it'll translate to success for our international professionals joining our workforce as well, for sure.
Yeah, well, you have to create a safe, inviting environment, right, to attract and to retain this talent. Um, so, Sahar, in my previous conversation with Kristen Winter, which has been echoed by many, there are significant ethical concerns around, I guess, aggressively recruiting, sometimes defined as poaching, internationally educated professionals from other countries. So, how does this work answer that issue from your perspective?
Um, I think like we've, physicians and other health professionals, they are commonly moving from one country to the other, right?
Mm-hmm.
You really can't tell them what what to do, right? So we're observing a lot of movement. And when I was doing some research and reading what are the factors, so there are different, um, theories why they move. Is it their success in their, in securing a job? Is it the country and what they're offering? Is it better wages? Is it better salaries? Is it better even environments? Are they coming to another country as a refugee, right? Are they leaving from a war zone? So I mean, like, there are lots of definitely factors that play into the movement of healthcare professionals from one country to the other. But my sense is that uh, what we are interested for it and for really is really how ethical is it to uh, to brain waste the ones who have come as immigrants to Canada. I think that's the talent. That's the question. I think this is the unethical, right? Where
Mm-hmm.
we're interested at N4. It's these, internationally educated health professionals have invested in themselves a lot. They have invested time, they have invested in getting their degrees, they've invested years and years of really attending to to patients and to even supporting the families of these patients, and they decide to come to Canada. And here we are not doing a good job in really making them welcomed and really being able to build on their expertise and integrate them into the system. For me, that's the brain waste. That's the unethical that really has to be addressed. And I think uh, we have started doing some reach out to employers and really understanding the HR process when really they are recruiting from abroad. And it's way less right? It's way less than really the, as Christine was sharing, the IEHPs who are already in Canada and are not being, part of the system. I think we've heard from many, and one of the our most recent webinars was with the internationally trained physicians from Ontario, who have come together to voice their concerns during COVID-19. They actually were very concerned, and they were not being offered any opportunity to share and to support our community during the COVID-19, right? It's not easy to feel that you are able to help and you're not able, right? You're being disabled, because of this license process, and it's and we it's just it's amazing that they have a voice now. And I think what's really, we really should be helping them, really look at our, how can we integrate them properly, right? How can we make the time less? We are not saying we don't need to do assessments. We do need to do assessments. We need to make sure that, they are totally capable of practicing, but it's just those, the lens of those assessments, the procedures and the practices that really needs to kind of, be kind of maybe revised, or we need to rethink about, outside the box a bit.
Yeah, and I think you're giving us lots of, I mean, why one, I like the lens that you put on this in terms of, it's not that we necessarily need to open the door wider and let more people into the country if we're not providing opportunities for those that we've already welcomed here. And so, so yeah, I think focus our attention there. But I think, as you're saying as well, we need to certainly change the way our own, I guess, paradigms and lenses in terms of how we see people and our systems in that space to I guess assessments shouldn't necessarily be barriers. They should, in some ways, from an education perspective, they should be enablers, right? They should be a way for creating skills as opposed to limiting access. So maybe sort of building on that and the roles around leadership in this space, Christine, what more do you think that we need from other health leaders to support the amazing work that you're doing?
Well, definitely, we need more leaders like Kristen Winter to step forward, be innovative, and be open to new ways of doing things. So, they need to be open to thinking about that bridging opportunity, to supervising, to providing opportunities, to think of it not as a risk management issue, but a way to enhance access to services for their patients. We tend to, there's definitely a bias that there's a presumption, oh, you don't have Canadian experience, it must not be equivalent.
Mm-hmm.
That's a false notion for sure. Maybe they have different levels of experience, and we could supplement that, and seeing them as investments that we can promote and retain. And so what we found in international providers is they're much more grateful to get jobs than Canadian born. They will be very loyal to your organization. I don't think people realize that as well. There's such a gratefulness when they do land in the jobs that they've wanted for so long. Look at all the hoops they're going through. Once they're there, they want to stay. They don't want to risk moving from an organization. So I think they need to see them as an asset. The other thing is continuing to do that EDI work, because again, that retention factor, they will leave if they're not welcomed. If there is ongoing racism, systemic racism, microaggressions, eventually that will wear on people and they will
Mm-hmm.
leave. So I think you need to look at that. That's for Canadian born and your internationals. And then staying attuned, there are people's feet are a bit to the fire. All the, Ministry of Health was given a 2-week a goal for both the College of Nurses and the College of Physicians to come up with innovative ideas. We're all under the gun in terms of this human health crisis, and it's still growing. So we need to get on top of this. This is not a short-term problem we're solving. This is a long-term problem. So we need long-term solutions. And so to think about implementing things not for some pilot project or for 3 months we'll do this or that, think about implementing this long term. We are relying on Canadians, on immigration to fill jobs permanently in Canada. That's our reality, and I think people think it's just a temporary thing, but it's not. So you need to think about this as a long term solution and not a quick fix. And think about, those opportunities for those who are in those training to have them come and be shadowed at your organization. So start thinking about nurse mentors who can shadow these nurses and provide that experience at your hospital, or the physicians who maybe are doing other roles while they're doing their exams and so forth. So being open to those innovative approaches and keep abreast. Like, stay tuned with N4, because we're going to bring forward all these best practices that we're coming across as we've done these needs assessments across Canada. We're coming up with some really innovative practices that people have implemented, and we're going to bring those forward for others to, beg, borrow, and steal from each other, is what I always say.
Yeah, no, and that's great. And be sure that when we air this, that we'll provide a link back to N4, where people can continue to follow you and learn from those practices. And I am struck as well, Christine, in terms of your own role, because of your within your job title is around the equity diversity side of things, and the patient experience part of that lens. And here we're talking about newcomers too. And I don't know that maybe everybody in healthcare is connecting those two things as really important. But I think a part of what you were describing that sort of strikes me as well to accentuate is valuing the difference that these people bring. Their diversity it shouldn't be a limiter, right? They're not Canadian, they don't have Canadian experiences, and therefore they're less than. That their diversity actually brings incredible assets and value that we should be capitalizing on, quite frankly.
Absolutely. And the comfort you see in your families, your patients and families, when they see somebody who's of a similar background to them, it's just so comforting to feel like, oh, they see me, they recognize me. It may not be the immediate provider, maybe it's just in the hallways in your organization, but it just decreases the anxiety. And we often forget to think about, what if this was us? If Canada, for some reason, it wasn't our country of choice and we went to another country, imagine how comforting that would be to say, oh, there's another Canadian, they know me, we'll talk beaver tails and Timmy's. It's just like something that reduces anxiety. So diversifying your workforce is incredibly important to our communities.
Yeah, well said. So Sahar, maybe in the end, I mean, what do you see as success for N4?
Well, I think we've come a long road. We've built we built
A long
N4
road in a
from
short time. Yeah.
yeah, we built N4 in a so we've always been aiming to kind of support our stakeholders. So in the same perspective, I think our success would really be supporting our stakeholders who we have now, we've been working with for a number of months now on the health human resource crisis, and really support them. And we are hoping at the end of with each table, with each working group, to come up with actionable recommendations that we can advocate for. And this is just for the internationally trained physicians and internationally educated nurses. As I shared, we just focused, we're focusing on them for this year. But our hope is that we will be able to advocate with the government, with the ministries, with the different decision makers on the recommendations that we'll have. Will, as Christine said, will bring best practices. Already many provinces have started implementing change, so they are, and we're hoping to be able to kind of showcase those and be able to say, hey, these are things that have, they have been implemented, and maybe you can give it, you too can give it a try, and maybe even engage, others in discussions. Maybe some are interested to hear and they're not ready to take the step, but we can help them, right, in taking the step and thinking outside the box, and maybe making changes to the process of the licenses for the IEHPSs. Another dream for N4, or another
Mm-hmm.
another success would really be um, hearing that the more employment opportunities are offered for the ITPs and IENs. So our, again, our lived experience table will be working with them very closely. We have an eye on that. So we're hoping also, all the recommendations that have been done and have been presented to HASA, from the Canadian Medical Association, the Canadian Nursing Association, we can advocate for those recommendations to really happen. So increasing the residency spots, right? Less discrimination when you're going through the whole process. Again, I think um, maybe we need to maybe work with the employer more, so maybe more awareness of the of the value of employing IENs and ITPs. So that's a piece that we're hoping to kind of work more with the employers on. And SPU, so I think the program, for the program that we have with the 3 months program that we have with the SPU program, our hope is that it would not be only offered to 3 cohorts, but we will continue to offer it, right? We heard over and over that understanding the Canadian culture is a piece that they really need. So we're hoping this would kind of become available for all, our IHPSs as they come into Canada, the ones who are here and the ones who are coming and immigrating over the years. So that's another thing, that this program becomes kind of, something that's already becomes available for them, right? Another piece that we heard is the mid-career. So mid-career physicians and mid-career nurses that they come into Canada, there isn't really a path for them, right? So creating that change of looking at, mid-career physicians and nurses who come in, and they do not need to redo, right, the exams and and take residency. Maybe again, that's something that we heard a lot from our site visits. So that's something that we would like to work on. um, uh, Similar to our work with the ITPs and IENs, we are hoping that we would be able to work on the other IHPSs, right? So similarly, we would have, a community of practice discussing, pharmacies, pharmacists and their path into, licensing into Canada, OTs and PTs and all the IHPSs. So again, that's something that we're hoping we'll be able to kind of given our experience with the ITPs and IENs, we will be able to also do similar work for the rest of the IHPSs. Yeah.
Thank you, Sahar. And maybe just exit a final question, sort of in that space. So, I mean, we've obviously, and there's a lot of attention placed on the regulated health professionals, nurses and physicians, and you've described others that are certainly areas of need as well. What about, is there a role or an opportunity for those other perhaps non-regulated professions as well, where, there's people who can support this or find pathways in? I mean, we've been hearing pre-pandemic about right, an overwhelming need for more PSWs as an example. And are there ways to sort of also attract, I guess, new Canadians or into professions like that may be also easier access points that don't have the same level of regulatory or licensure requirements? Just maybe a question to either of you.
Definitely, you see that the internationally trained nurses, a lot of them are go for that jobs if they know about them. So definitely, we need some innovative thinking in terms of recruitment for those jobs. If you can think outside your usual boxes of, we put it on our websites. If you reach out to those communities, you might see a greater interest. And again, right, diversifies your your workforce, which is an added benefit for the hospitals. A lot of the IENs want those jobs. It gets them, as Sahar mentioned, you have to have recency of practice to show to get a license, and that allows them to show I'm in the Canadian system, I'm doing this work while they're pursuing their license. Because for nurses, going home typically is not an option. The way physicians will fly home and do 3 months back as a physician, for nurses that's not an option. So for them to, they can do those jobs, get that recency of practice check mark, and while they await their licensing or they're doing their bridging program or so forth. So it's definitely
Thank you. So, I mean, I think, we often hear about Canada as being the land of pilots. And I think that an organization like N4 is finding a way to harness, I think, those innovations and ideas and help spread and scale them, which is something that we need across the country more than ever. Thank you for all the great work that you've started to do, will continue to do. Thank you for joining us today on the podcast, and for sharing that and hopefully connecting people to your work for continuing on that journey together.
For the opportunity.
Thanks a lot.
You've been listening to the HQ, and I'm Dale Sherbeck, your host. You can find this and other future episodes on the CHA Learning website, Apple Podcast, or Spotify. We'd love to hear what you think, so please follow us on our other social media channels. Thanks for joining us in this discussion today. Please join us next time.